Hi everyone. So as you know, our patient has hypertonicity because of a stroke. And my approach is the Rood approach. And the Rood approach, it's about replicating normal motor development to achieve purposeful muscular responses. So basically, it follows a normal movement pattern. These movements begin at developmental level of functioning, such as when you're a baby, and then it progresses and has a functioning and it has a sequence. And this sequence begins if the patient has either hypertonicity or hypotonicity. And since our client is hypertonic, the only techniques I would use is roll over, pivot prone, neck co-contraction, on elbows, all fours, and then standing. These techniques will help the individual use less tone and weight bear on the affected sides so their CNS receives more information. So the four principles of the Rood approach is that reflexes can be used to assist or to retard the effects of sensory stimulation. The second one is sensory stimulation of receptors can produce predictable responses. The third one is muscles have different duties, either as a stability or mobilization. And the fourth one is heavy work muscles should be integrated before light work muscles.
Rollover. This technique focuses on the patient to flex the affected arm and leg properly. It activates the UELE intramusculature. This pattern is encouraged for patients who are dominated by reflexes or who need segmental movements of the extremities. Pivot prone. This position requires extension of the neck, shoulders, trunk, and LE. This pattern is both mobility and stability while being difficult to hold. It plays an important role in preparation for stability in the upright position. Neck co-contraction. This is the first real stability pattern. It is used to develop head control and stability of the neck. This pattern is necessary to raise the head against gravity. On elbows. On elbows. Weight bearing on elbows helps achieve stability in the scapular and shoulder regions. This position gives the person a better view of the environment and to shift weight from side to side. All four. This pattern develops the stability of the trunk and legs. Once the patient can hold its position adequately, then they can shift their position onto the affected extremities. This weight shift may be preparatory for balance. Static standing. Static standing focuses more on the LE with equal weight on both legs. Then, as the person advances, weight shifting will be used. This obviously requires higher level integration, and the client may not reach this pattern for weeks.
My patient has sustained a stroke and she's an elderly woman. So I will be showing you the proprioceptive neuromuscular facilitation technique of diagonal patterns being D1 flexion and extension and D2 flexion and extension. So you facilitate these movement patterns through manual contacts, verbal commands, and visual cues. One of the goals of PNF is to establish balance among opposing muscle groups. For example, if a patient demonstrates a flexor synergy, then extension should be facilitated. Verbal commands should be brief and clear, and visual stimuli help to initiate and coordinate the movements to increase speed and accuracy of motor performance. The patient needs the opportunity to practice these patterns. So now I'm going to show you the PNF techniques. Okay, since this patient's left side is affected, I'm going to be starting on their left side, manually providing resistance. So going from straight arm down, going over like this. This is D1 flexion and extension. So the shoulder is going to be extended, abducted, and internally rotated. I'm going to go really slow, making sure the forearm is pronated. And hand will be extended and abducted. The scapula will depress, it will retract and downwardly rotate. The arm will go across the body to the opposite shoulder, and then the forearm will be supinated. The fingers and thumb will be radially flexed and abducted when it goes back down. So that is how you do D1 flexion and extension. You go slowly and be providing them resistance. So for this patient, still on the left side, affected side, but now showing you D2 flexion and extension patterns. So this is actually supposed to be a quick stretch for this stroke patient. So kind of like the first, but starting on the opposite side, going up like this and over across the body here. So the shoulder will be extended, adducted, internally rotated. The scapula will be depressed, retracted, and downwardly rotated. The forearm will be pronated, ulnar deviated, and fingers and thumb flexed and abducted. So moving the arm all the way up, flexing the shoulder, internally rotating and depressing the scapula. The wrist will be flexed, and this moves kind of like unsheathing a sword. So starting from here and bringing it up like this. Okay. Thank you, ma'am.
No problem.
So the technique I chose was NDT, also known as the Bobath approach. And the NDT technique has three principles. That's to normalize tone, inhibit primitive patterns of movement, and facilitate automatic voluntary reactions and subsequent normal movement patterns. I'm choosing to do bed positioning with NDT today, and our client has had a stroke and their left side is affected. So in order to do this, you're going to want to have the patient roll towards you. So they're going to take their unaffected leg and bend it up with the foot flat and the unaffected arm across their body. On the count of 3, roll towards me. 1, 2, 3. Now they're laying on their affected side, providing weight bearing to that side, and you can place a pillow behind their back so they can't roll over. The unaffected leg would then be bent or flexed to about 90 degrees, and a pillow would be placed underneath it. The affected leg continues to be straight to provide weight bearing to that side. The affected arm would be fully protracted, the elbow and 90 degrees, the shoulder would be at 90 degrees with the elbow flexed and the hand placed underneath the pillow to provide weight bearing to that arm. Also, the head needs to be on a pillow, but avoid hyperflexion of the neck. What this provides is weight bearing to that side so that it can increase awareness to that affected side of that body. And that's bed positioning with NDT. Now to do weight bearing using NDT while the patient or client is standing, you're going to want to have them place their hand flat on a surface like a countertop or a tabletop, their affected hand. And you want that hand to be flat and several inches from the hip, with the shoulder externally rotated and the elbow extended. And you can also use NDT while doing this with a purposeful activity, so doing ADLs or IADLs while you're doing weight bearing. And what weight bearing while standing does is provide sensory input to the affected side, and in this case the left, and it increases awareness for the patient to the side. And that's NDT with weight bearing while standing.